welcome everybody, and thank you for joining us for what I hope will be an interesting and informative discussion around some of the latest and most interesting data in rheumatology. My name is Professor Peter Nash from the Griffith University in beautiful downtown Brisbane in Australia, and today we're very fortunate to be joined by Dr. Derin Karacabeyli, a rheumatologist, a research trainee at the Arthritis Research Canada and resident in the University of British Columbia Clinical Investigator program. It's a pleasure to have you join me today, Derin, to discuss a recent paper of yours, which I think is very important and has major implications for the way we manage our patients, particularly those who have a BMI over 30, now, which is an increasingly common problem amongst our patients for a variety of reasons. The paper is titled Mortality and Major Adverse Cardiovascular Events after the GLP-1 receptor agonist initiation in patients with immune-mediated inflammatory diseases and type 2 diabetes. It's a population-based study, and it was done in partnership with the Arthritis Research of Canada. So welcome, Derin. Can you tell us a little bit about yourself first, where you work and what you're working on, and then we'll talk about the paper.
Sounds great. First of all, thank you for the invitation. It's an honor to be here. So I just completed my rheumatology residency at the University of British Columbia this past June. And since then, I've started some additional research training. So I'm starting a PhD looking at the effects of weight loss therapies on patients who have autoimmune rheumatic diseases, or in this case, immune-mediated inflammatory diseases. I will also be working as a rheumatologist at Vancouver General Hospital in British Columbia, and I'm currently enrolled in the Clinician Investigator program at the University of British Columbia, and my primary work site is Arthritis Research Canada, where, as you mentioned, I am a research trainee.
Excellent. So just fill us in a little bit on the background of access to the GLP-1s. For example, in our country, if you're not diabetic, you really can't get easy access. Plus, there's been some supply issues. But interestingly, because weight loss is such an issue, compounding chemists are making it available at personal cost. So my patients who are not diabetic, could get Ozempic, for example, for about $140 a month, which is not too crazy if you said, let's just take 6 months and lose 15 kilos and then stop and try and keep it off. And even Mounjaro now, the dual agonist, which you'll tell us about, you can get for about $300 a month. So these aren't crazy over the top, but it's still an issue about cost and access. What is the cost and access like in Canada?
So in Canada, I work in British Columbia. And in British Columbia, it's similar to, I guess, where you work, where in order to get coverage for a GLP-1 receptor agonist, you need to have diabetes. And in fact, as of 2023, you need to have been on metformin and had inadequate glycemic control on metformin. I mentioned 2023 because it was a positive change in which prior to 2023, you would actually have to fail both metformin and a sulfonylurea before you'd be eligible for either a GLP-1 receptor agonist or an SGLT2 inhibitor. So now they've been approved as second line for the management of diabetes. That said, we're in a similar boat where they are not covered for the management of obesity or excess adiposity. And as a result, patients are paying out of pocket to receive the medication if they want. There are certain extended drug plans that will cover it for the indication of obesity in British Columbia. And as a result of that, that's a way that some patients get it. Unfortunately, that in itself can create some kind of socioeconomic discrepancies and gaps in care where those who may be of lower socioeconomic status or don't have extended health coverage can then not access the medication. And so that can create problems in and of itself.
But it's not approved for obesity per se, like in the US.
It's currently approved in Canada. Health Canada has approved semaglutide at obesity dosing, or I guess the brand name would be Wegovy. So that is now an approved indication, but it's not covered in the province of British Columbia.
Exactly right. The same here. The TGA has approved its use for obesity, but it's not reimbursed by government. Okay. So tell us a little bit about your population-based cohort study. Tell us a little bit about how you can get access using the ICD-910 codes.
Of course. So we're very lucky in British Columbia. There's this I guess this institution called Population Data BC that can partner with research organizations and anonymously, after completing the relevant training on confidentiality and data privacy, will allow access to different databases to allow researchers like myself and my study team to answer questions. And so the beauty of this is we then have access to data sets which cover the entire population of British Columbia. So this allows us to have a very representative group. Everyone in British Columbia is included. So what we get with our data set, for example, we have something called PharmaNet in BC, whereby all prescriptions that have been dispensed and filled at pharmacies are recorded. So using that data, we can see every single individual in British Columbia during a specified time period who's been prescribed, for example, semaglutide. So, sorry, go ahead.
So can you actually tell who's prescribed but persist with therapy, or they might not fill a script or take one script and then take no more?
Right. So we can tell who's filled the prescription. It'll say who filled it. And then we can then see at different intervals who has filled it again. So we're obviously not able to see if people physically take the medication or if they inject it, but based on whether or not they filled it and then filled it at discrete time intervals in the future, we infer that they are taking therapy, and there are limitations to that.
Do you get a feel for how many start and stop quickly and how many persist?
That's a great question. We're actually looking into it because, especially with the GLP-1 receptor agonists, there is that early increased, I guess, a GI intolerance that takes place. And once people can get past that initial couple months, often people can stay on therapy longer term. That's what's seen in the RCTs, not in patients who have immune-mediated inflammatory diseases or IMIDs, but in those with diabetes or obesity. In our data set, we're going to look into it further. We did perform a sensitivity analysis in our study, excluding those who received 3 months or less of therapy, and we found consistent results, which we could talk about. But that is something that we will look into further.
And you've limited it to diabetes because it would be very difficult to do it for primary obesity and those people paying out of their own pocket.
Not only that, but because unfortunately with our administrative data set, obesity is somewhat poorly or inadequately captured because we are relying on billing codes. We are exploring ways where we might be able to capture those who have obesity. However, for now, for this study, we thought that it would be cleaner to focus on a population where we have validated administrative definitions based on ICD codes for diabetes, and take it from there. The other challenging part in a study like this would, if we were doing it in obesity, would be to find a relevant active comparator. So in this case, we were able to use a population with diabetes who started a cardio neutral, weight neutral, similar second to third line agent in dipeptidyl peptidase 4 inhibitors. But with obesity, that's a little bit more challenging. So those were the two main reasons why with this study in particular, we limited to patients with diabetes.
So British Columbia population about 5 million. This is a large study of over 10,000 patients. And tell us a little bit about the methods of this study in particular, and just try and explain a sequential propensity score for the listeners, please.
Of course. So what we did was we took the population of British Columbia And then using billing codes in British Columbia, ICD-9 and 10 codes, we first identified all patients who had diabetes with one of the immune-mediated inflammatory diseases. I'll just say IMIDs from now on, so it's a bit easier, with one of our IMIDs of interest. So those included rheumatoid arthritis, psoriatic disease, axial spondyloarthritis, IBD, and systemic autoimmune rheumatic disease, including both connective tissue diseases and systemic vascular disease. So once we found all patients who had diabetes plus IMID, we then assembled two separate cohorts, one of new users of GLP-1 receptor agonists and one of new users of dipeptidyl peptidase 4, DPP-4 inhibitors. These patients could have had no prior exposure to either of the two agents. So one,
Now, what's the theoretical difference between the DPP-4s and the GLP-1s?
Sure. So the mechanism through which they work, so GLP-1 is a naturally occurring incretin in the body, so it is an insulin sensitizer to some degree, and then it also delays gastric emptying, so it slows down movement through the gut, and it has an appetite suppressing effect in the brain, and those are the reasons why it works for both diabetes and weight loss. GLP-1 in the body is broken down by an enzyme called DPP-4. And so the way GLP-1 receptor agonists work is you are getting this large exogenous load of something that looks like GLP-1, but is not broken down very quickly, because the challenge with administering straight GLP-1 into patients is it just gets broken down right away. Versus DPP-4 inhibitors, what you're doing is you are giving somebody a drug that inhibits the enzyme that breaks down the GLP-1 that you already have. The challenge is that, it's not the challenge, but the thing is that DPP-4 inhibitors, or I guess simply inhibiting the enzyme, does not induce a GLP-1 response that's large enough to cause weight loss. And so these drugs have not been found to be weight lowering. What's interesting is they've also not been found to have the same cardioprotective effects as GLP-1 receptor agonists. So mechanistically, there are some similarities, but in terms of what we see in clinical trials, GLP-1 receptor agonists are more effective in managing glycemia, and they are also they improve weight, and they are cardio and nephroprotective. That's actually a more recent study showing that as well.
So the DPPs act as your controls because they shouldn't impact on weight or cardioprotection. Was it an option to use 10,000 socioeconomically similar controls, or would that have been too tricky?
What do you mean? Like people who did not have any therapy? Is that what you mean?
Yes, people who had diabetes but went on either drug, or even people who same age, sex, socioeconomic status, but who weren't diabetic.
Who were diabetic. I think the challenge is that we wanted to capture a population who is still receiving treatment, because I think it would be difficult to find a patient in a diabetes population who had indication for a GLP-1 receptor agonist, and then find a similar patient who had similar glycemic control but was on no therapy. And so for that reason, we were trying to find an agent that was similar line of therapy in BC. And so in BC, the way it works is you get metformin first, and then second line is one of either a sulfonylurea, which are kind of falling a bit out of favor, a GLP-1 receptor agonist, an SGLT2 inhibitor. Those two, the two that I just mentioned, have become way more popular, or a DPP-4 inhibitor. Now, the reason why we didn't use SGLT2 in this study, and it's something that we're thinking about pursuing in the future, is because they also have some weight loss effect. And so we thought that if the hypothesis was that weight loss could potentially be one of the mechanisms through which this was working, we would then not bias, but we would, I guess, trend towards the null if we were using another drug as a comparator that can cause weight loss. So I guess to answer your question.
Yeah, keep going.
I was going to say, to answer your question in a bit of a roundabout way, we thought that it would be difficult to find a matched or similar population that had no anti-diabetic agents on board.
Okay, excellent. And you did look at a whole variety of immune-mediated diseases, but the bulk of them were which particular one? Rheumatoid or?
About 80% were so about 40% psoriatic, 40% rheumatoid. So 80% was psoriatic or rheumatoid. And our definition of psoriatic was psoriatic disease. So it included both psoriatic arthritis and psoriasis because there are some challenges in administrative data in distinguishing the two. And so we decided to lump them together.
Okay. So tell us a little bit of how long you followed these patients up for as a mean and as a median, just to get a feel for how long you gave them to have a cardiovascular event.
So there were differences between the two groups. So in the GLP-1 group, it was about a year and a half on average, compared to just under 2 years in the DP4 inhibitor group. So in our, we called it our as treated arm, which was the analysis, that was our primary analysis. There was a bit of a difference there, nearly half a year, a little bit less. We also performed kind of what tried to mimic an intention to treat model in a sensitivity analysis, and that followed patients for nearly 5 years. And we found our results were still significant in the intention to treat analysis, but the hazard ratios were less dramatic, I should say. So they're more conservative estimates, which I think is fair. Our study period started in 2010 and went all the way to 2021. So we did have over 10 years to follow patients, but as we were talking a little bit about earlier, I suspect that the reason why we had a shorter duration of follow-up with the GLP-1 receptor agonists was because there are more patients who will get GI side effects earlier on and then discontinue therapy.
Excellent. And because we might talk about those side effects later, your primary outcome was all-cause mortality, and your secondary was MACE and the components of MACE. Tell us a bit about those outcomes.
Sure. So all-cause mortality, we collected through vital statistics through the province of British Columbia. And then our composite outcome of MACE included myocardial infarction, stroke, and death from either myocardial infarction or stroke.
So we would call them fairly hard outcome measures. So
Yes.
tell us a little bit of, was the stats important? Was there anything tricky about how you did the stats?
Yes. Yeah. No, that's a great question. So I learned a lot doing this project about statistics, and I'm looking forward to learning more throughout my PhD, because I learned the value of using techniques like propensity score overlap weighting. So essentially what you're doing when you're calculating a propensity score is you're calculating the probability that somebody will be in a specific treatment group. What we did in our study was something called propensity score overlap weighting. So first you calculate a propensity score, how likely somebody is to be in a group, and then you compare propensity scores. How likely is somebody to be in one group versus the other group? So those who fall at the extremes, those people are very unlikely to be placed in the other group. So for example, you can look at individuals who got GLP-1 receptor agonists, and based on their baseline characteristics, you can see how likely they would be to get a DP4 inhibitor based on just their baseline characteristics. And so different techniques, you can then use that calculation to kind of help adjust for potential confounding. So probably one of the most common techniques is doing something called propensity score matching, where you essentially find those who have very similar propensity scores and you match them. And that way you're achieving two cohorts that are very similar at baseline. The challenge with propensity score matching sometimes is that you lose a lot of people, because those who you can't find a good match for, you just have to exclude them. The benefit of what we did, propensity score overlap weighting, is nobody is excluded, but rather those who fall at the extremes, those with propensity scores that are more difficult to match, those individuals are actually just down-weighted, and those who have the most overlap are upweighted. And so you create a cohort that two cohorts that includes everybody. However, those who are less likely to have received the other treatment, hypothetically, contribute a lot less to your analysis. And so this was all new information for me because I don't have a stats background, but I think it's a relatively powerful technique. And that's why we chose to employ overlap weighting over matching.
And in your table, you compare before overlap weighting and after overlap weighting. And which should we focus on, the after overlap weighting?
That's what I would say, because after overlap weighting is the group that we performed all of our analyses on.
Okay, so they're in their 60s, under half male. You've looked at neighbourhood income, you've looked at health regions, you've outlined the immune-mediated diseases. These people had long-standing disease. They have mean duration of 13 years. You looked at their Charleston Comorbidity Index, and they had a lot of usual kinds of things like hypertension, some history of myocardial infarction, 13%, and CV about 15% had, if I'm reading that correctly, their percentages of that.
Those are percentages, correct.
Yeah. So they've got the usual kind of background risks, diabetes of 11 years duration, some with diabetic complications, lots of different medications, for example, cardiac aspirin only in 3.5%, and some COX-2 use in there, 18%, which might be considered a risk, about 7% on a biologic or a JAK to complicate things. And so, a very representative group. Do you have a feel for incidence of MACE and infarction on a kind of yearly basis in this population? What would we expect? And then to give us a feel for whether the medication actually reduced that risk, if you know what I mean.
I see what you're saying. So what I would say is probably our best estimate of the incidence rate would probably be the DPP4 inhibitor groups rate, just on the basis of we expect this to be cardio neutral. And so what we have, I'm just referencing my table here to remember the exact number, but we had 32 events of MACE per 1,000 person years.
So and that's a kind of feel for the expected background rate, and then we can look at the treatment effect. So tell us a little bit about all-cause mortality, some of your results, please.
Sure.
And we'll go through them. All-cause mortality.
So with respect to all-cause mortality, we observed 28 events in the GLP-1 receptor agonist group amongst about 3,600 patients, versus in the DPP4 group, we observed about 446 amongst just over 7,000 patients. So the incident rates were 8.5 per 1,000 person years with GLP-1 receptor agonist exposure versus about 18 with DPP4 inhibitor exposure. And this yielded a hazard ratio of 0.48. Again, these are adjusted hazard ratios after performing propensity score overlap weighting. So relative risk reduction of about 52%, which I will acknowledge is a lot higher than what has been observed in the RCTs. And and when we performed our intention to treat analysis, it was more reflective of what's seen in the RCTs. So what RCTs observe is probably in the range of more about 10-15%. I suspect that our findings may have been because our population perhaps was a little bit sicker with more comorbidities, so more likely to see a difference, especially in a real world setting. But also I have to acknowledge that there is certainly the possibility for some residual confounding despite our statistical techniques.
That's still pretty impressive. You halve the death rate with a number needed to treat of about 110 for a year to save one death. That sounds pretty impressive to me. And you couldn't get a feel for whether that increased over time or was fairly constant over time.
I'm just looking at our Kaplan-Meier curves, and I mean, there was a bit of a divergence in the curves over time, but I would say relatively constant.
Numbers are too small. That's fair enough. So that's still pretty impressive. And there was no way of baseline predictors who were going to have those events.
You mean in terms of who might have been more likely to die at baseline?
Yeah,
I mean,
numbers
there
are
are
too small, probably.
yeah, I mean there are predictors, but I think that what we tried to do is we tried to balance those baseline predictors in order to adjust for that with our statistical model. But as you said, no, it'd be an interesting thing to look into further.
Excellent. And tell us about the major cardiovascular events.
Sure. So similar findings in the GLP-1 receptor agonist group, 83 events amongst the 3,600 patients versus 632 in the DP4 group with 7,300 patients. So the incident rate for 1,000 patient years with GLP-1 exposure was 21.5 compared to 32 in the DP4 inhibitor group. So hazard ratio here was 0.66 and rate difference was 10.5, so 10.5 lower with GLP-1 receptor agonist exposure. So 34% relative risk reduction in this case.
And again, out of, very large numbers of patients, 10,000 patients, that's a number needed to treat of about 90 to prevent a major adverse cardiovascular event, including stroke and infarction. So that to me is also pretty impressive. And again, Kaplan-Meier, it didn't escalate over time. It just stayed fairly steady over time.
Exactly, yeah.
Okay. So any other results that you want to highlight for us?
I think the other thing to mention, so we tried to perform some subgroup analyses as well to look to see if we could observe similar differences in certain groups, or for example, in those with rheumatoid arthritis or those with psoriatic disease. And so we still did observe statistically significant reductions in mortality and MACE in those who had RA. But in psoriatic disease, we observed a trend towards benefit, but it didn't reach statistical significance. So that's noteworthy. We didn't have enough power to look at the other diseases, but it's something that I think would be very interesting, especially as uptake of these medications increases over time, numbers will just go up. The last thing that we looked at, which is included in the supplementary material, is another hypothesis that we had was whether or not patients with IMiDs would benefit more from these drugs, because patients with IMiDs were at higher risk of these outcomes. And what we did is we essentially assembled two more cohorts in patients without IMiDs and did the same study design. And what we found was that the benefits were about the same. So we're not observing a greater benefit in those with IMiDs than those without. It's similar in our study. So I think that's important as well.
And you wouldn't have been able to examine the amount of weight loss these two different groups of patients had?
I wish. Unfortunately, not with our administrative data. That would have been, I wish.
And again, you also couldn't have looked at the baseline group whose BMI was over 30 compared to less than 30 at baseline?
Unfortunately, in our administrative data, we don't have heights and weights, so we don't have BMI. I know that some research groups are able to get subsets are able to link some patient-reported data with their administrative data. We didn't have that, so we weren't able to do that. But I think where this research is moving is looking more specifically at, as you were alluding to, obesity as the risk factor and potentially as an agent that can be addressed with therapy that will subsequently reduce risk.
Fascinating, because roughly 22% of your cohort had a diagnosis of obesity, which I presume is a BMI over 30. So we're kind of artificially making that a cutoff to think about our immune-mediated patients with a BMI over 30 and trying to find a way that they might benefit from these drugs. But it might be just as beneficial if your BMI is over 25. I just don't know the answer to that. Congratulations on a very important paper, which I think has implications for how we treat all our patients, particularly those with elevated BMIs, and lots of risk factors: hypertension, diabetes, hyperlipidemia, bad family history, smokers, etc. Any other take-home message you want to give to the practicing clinician?
I think the big take-home message for me is that, presumably a lot of the listeners will be rheumatologists or those managing patients with IMIDs. And so they themselves might not be I'm not sure what it's like where you practice, but where I practice, the rheumatologists are not typically the ones who are prescribing these agents. It's usually done by either the primary care provider or by endocrinologists, for example. But I think what we have as rheumatologists is the knowledge that our patients with IMIDs are at increased risk of cardiovascular complications, and do have a chronic hyperinflammatory, or do have a chronic inflammatory state. And obesity in itself is a chronic inflammatory state. So if we can work together with our colleagues in primary care or endocrinology to identify our patients who are at risk, who may benefit from these therapies. In our study, we identified, for example, those with diabetes and an IMID, that combination would benefit from this. So I think simply connecting with your colleagues who may be more comfortable prescribing these medications, if indicated, and working together to ensure that patients are on appropriate therapy. That would probably be the big take home.
Excellent. And the one thing we haven't mentioned is on the safety side, were you able to comment on the things that people try and scare patients off these drugs? Thyroid cancer, pancreatitis, gastroparesis with complications. So do you have any comments on the safety aspect and any comments on whether people tolerated these drugs well and persisted with them?
So that is going to be part of my PhD. I'm going to be looking at the safety profile of these agents as well in the IMID population using administrative data, but I don't have that information right now.
So that's the other very important piece of the puzzle. But I congratulate you on a very interesting study. We look forward to more publications. We'd love you to have different control groups to compare rates with and to follow these patients up for longer, because really, if you could reduce this major adverse events over 12 months or 18 months, imagine what you could do over 3 to 5 years. So we thank you again for your time, Derin. If you'd like to know more about this paper and others uploaded to the Immune-Mediated Inflammatory Disease Forum website, you can get detailed slide sets are available at imidforum.com. Please subscribe to this podcast on Spotify or iTunes or other podcast media. Let us know what you think. We're always keen to get some feedback. You can also watch us on the IMID Forum on YouTube. And finally, you can follow us on Twitter, LinkedIn, and Facebook to keep up with all the newest data on the IMID content coming soon in 2024. Thank you so much, Derin. Greatly appreciated.
My pleasure. Thank you.